all over body pain, fibromyalgia, myofascial pain, and they're being prescribed cyclobenzaprine, whether it's 5 or 10 milligrams, 1 to 3 times a day. They're the benefits of muscle relaxants in these kinds of conditions are no better than either placebo and certainly inferior to tricyclic analgesics. So that's something I think we really need to keep in mind, because the other part about this is that when you discontinue muscle relaxants, so if you say, all right, I'm going to bridge somebody to find a way to get to better treatment, I'll start them with muscle relaxants and we'll do some other things that might be effective in the long run. What you find is on discontinuation, any benefit you had reverts back. So it's really kind of a bridge to nowhere for individuals. And so the recommendation is really strictly to avoid that, with a few very specific exceptions. One of those that's kind of interesting is that there is some benefit seen in trigeminal neuralgia patients with tizanidine when it is added to carbamazepine. So tizanidine, some of us understand that as an alpha-2 agent as well as a muscle relaxant. Obviously, trigeminal neuralgia is a strictly neurologic condition, and it's probably a central neurologic condition. So it's been shown to have some effect with that. Although the trouble with the combination with when you add tizanidine to carbamazepine for the management of trigeminal neuralgia, up to 35% of patients discontinue both treatments out of the adverse effects developing. So it's really kind of minimally effective, but is one to consider. Mind yourselves that trigeminal neuralgia is distinct from atypical facial pain. So it really needs to be the tried and true V1 through V3 electrical short shooting pain that goes away in less than a minute for tizanidine to be effective. Another one that we think about it, especially baclofen, we talk about spasticity and neck pain. There is some limited evidence that with short-term management of neck pain and associated spasticity in individuals that muscle relaxants do provide some benefit in this. Interestingly, however, when it's looked at against non-pharmacologic agents, even TENS unit therapy is considered to be superior in randomly selected patients to muscle relaxants of any kind. So starting the conversation out by saying, of all the treatment that we can think of for chronic pain, really don't think of muscle relaxants, even though we feel like we can be helping individuals in a way that doesn't add to their MME score and so forth. It's kind of a challenge to get these individuals better. So this slide is really this study here, and I think this is a really fascinating study, and I can make that available if somebody wants to look at it. And I'm going to talk about this one kind of quite a bit today, because now we get to those medications that are potentially very effective for chronic pain situation and effective in a sustainable fashion. And this is also kind of an important study because, Alex mentioned the OxyContin reps coming into our, those guys, at least Purdue doesn't bother our clinics anymore, but we still kind of spend a lot of time considering whether serotonin, norepinephrine reuptake inhibitors or membrane stabilizers are effective, and which ones are and which ones are not. How do we get a rational management of these individuals in a fashion that's effective and tolerated? And actually, there's a challenge with most of the industry's data because, the FDA doesn't let studies go head to head, right? So we can't sit here and compare serotonin drugs, norepinephrine drugs with membrane stabilizers, except in this study that was done here. And they really combined a great deal of information into one study and came up with some very, I think, important recommendations with respect to what medications are sustainably effective for the management of chronic pain conditions that are predominantly either neuropathic or we can think of these as nociplastic. And I would make the argument that almost every pain condition, at least in a mixed fashion, becomes neuropathic and nociplastic. The central nervous system is a learning structure. It changes over time. And what that means is that if you even if you start out with a strictly uh, musculoskeletal condition, whether it's rheumatoid arthritis, osteoarthritis, uh, uh, you know, tissue injury, over time, the central nervous system learns to become effective at this. So the management of these conditions really always needs to be, at least in part, considering that there's a neuropathic central nervous system component. And that's why these medications have the potential to be helpful at ameliorating the symptoms if we can be rational about how we do that. But the big challenge and the biggest issue with this is that the benefits are limited and they're subtotal, right? You don't get resolution of chronic pain with these medications. Really, I would say with any medications, it's not rational to say I'm gonna eliminate your chronic pain. What you're doing is reducing it, and you're reducing that global effect on activity and function and the interference associated with pain. So they came up with some really fascinating data. And what this is looking at is, first, what's the likelihood that any given therapy of all these selected in the study or all these looked at, what's the likelihood that this will provide substantial subjective reduction in pain? And they measured this typically as a 50% reduction in pain. And as you'll reflect on that, that's really about the best that we do with any medication, right? We reduce chronic pain by about 50% at best. And then what they looked at is what's the likelihood that that will be tolerable? And they came up with that they used the number needed to harm. How many times do we have an individual that we can get them to effectiveness, and yet they can't tolerate it, so they discontinue therapy? Or what's the likelihood that we can't get them to effectiveness? And the number needed to harm is how often do we find a patient cannot tolerate the amount of medication necessary to provide a meaningful reduction in pain. And then the last thing, obviously the number needed to treat, and that's really our big bugaboo. And I'll just, I think that's probably one of the reasons that I have continuing work is that the number needed to treat for any of these medications in the chronic pain space is somewhere between the high threes and up to 20. So what that means is anytime you start a treatment, you're going to have to start it for 3 or more individuals before one comes back and says, thanks, that's great, I tolerate it, and it's very effective. And so that's kind of what we're up against in this environment and what we see and our big challenge. And so these are way too busy slides, and I appreciate that you're looking at this like, what the heck is going on here? But there are some important take-home points, and what I'd like you to think about is that they're really looking at all the membrane stabilizers that we use and typically use, and dosage ranges of what's tolerable and what's okay with respect to toxicity. And then they're also comparing membrane stabilizers as well as norepinephrine or serotonin norepinephrine reuptake inhibitors, so the SNRIs. And what they came out with, which I just love, see if I can advance this, is substantial uh, um, benefit. The greatest benefit is seen with high dose duloxetine. Duloxetine at 120 milligrams a day has the highest likelihood of providing a 50% reduction in pain for individuals and to be tolerated and to have the least likelihood of being discontinued due to intolerable adverse effects. And the other one that's I think is kind of important is that similar to that and just very close to that is high dose pregabalin. And we're talking 600 milligrams. There is substantial benefit also seen with lower doses of pregabalin, but what we're seeing is with a 50% reduction in pain and and a likelihood to be tolerated, either high dose pregabalin or even better, high dose duloxetine have a pretty good track record with respect to improving um, uh, pain by up to 50%. The advantages seen for some of the other medications, again, depends on what it is that's affecting the individual. I mentioned at the start of this that I think what we have to measure are things like sleep interference. We have to think about what the effect of the mood, anxiety, what the effect of, the difficulties with respect to emotional regulation and pain catastrophizing, that influences our choices as well. For example, pregabalin is a good choice in an individual that has a great deal of sleep interference, right? We understand that it's more likely than some of the other medications to lead to some difficulties with sleep. And yet, if you can tolerate that, if you can get an individual to doses that are effective, then you're going to pick your side effect profile. A lot of times I'm really enamored with lower doses of pregabalin, as I'm sure many of you are, with respect to the likelihood that 300 milligrams a day divided doses is still going to do a little bit better with respect to sleep interference. And yet it's still going to, as you see here, it's still going to do a pretty good job at reducing pain and having a relatively low number needed to treat. And when I say relatively low, you'll notice that it's about 5 to 6. So, so, so the idea of that being an effective option gradually with patients really rises to the top. Um, the dropout rate is just unfortunately quite high. And the difficulties that we see with these individuals is pretty substantial. And um, that I think is the reason that it's difficult for these patients to be managed. It's very challenging to have these individuals sitting in your office month after month saying, it's still not working. I'm still having difficulties. What can I do? And of course, that's our challenge because that's when we start to reach for things that maybe are less likely grounded in data, and that's when we're going to reach for muscle relaxants and we're going to start to reach for opioids and what have you, with the idea that even though they may not be effective, I need to do something to respond to this individual because they're getting frustrated with the lack of efficacy. It also probably shows us the limitations of medications in a whole. And if there's a take-home point is if you can find a patient who will have meaningful reductions in sleep interference, improvement in functional status, some measurable way to determine whether their mood and overall global functioning is better, and yet have a 50% reduction in pain, you've probably reached a rational endpoint with respect to medication management. And now's the time to think about what other things are more effective. So some other things that I really wanted to kind of bring forward in our discussion today. Um, there was a long time when we had gabapentin around for so many years before we had pregabalin, and now I see all the time individuals who get to me and they're on those super high doses of gabapentin, and you feel like you can just ride with the provider kind of the rationale. Maybe they started at 900 milligrams, they got to 600, 900 milligrams a day. They had a little bit of benefit. The patient says, now what? And now what? And you're not wanting to go to those other more toxic medications. So you've increased gabapentin to the point where it's either crazy high doses and you're just metabolizing it away. You're not absorbing any of it, or the individual isn't. And yet, what do we do? And this study, I think, is kind of important in that it says even patients who are doing well with gabapentin will do more better, will have an increase in pain relief switching to pregabalin. Conversely, or additionally, individuals who fail gabapentin are still likely to respond effectively to pregabalin. The individuals who have been on gabapentin who switch over to pregabalin will get approximately a 25% improvement in pain relief, which is a meaningful reduction in our space. And individuals who have failed gabapentin, usually it's because they're only able to tolerate way subtherapeutic doses, have a benefit, have a likelihood of responding to pregabalin. So if you can individually tailor the dose, wean people away from gabapentin, they're really essentially similar in cost these days. But remind yourself that the pharmacokinetics of Lyrica pregabalin are just superior in the absorbability. and remind ourselves that really anything above 300 milligrams at a time of gabapentin is just being sent to the renal tubules anyway. So try to avoid those really high doses of gabapentin and find yourself staying away from that. This next one, this next study is talking about, and this speaks to what I was talking about a little bit with respect to the physiology of the conditions. Functionally, functionally, all chronic pain becomes some degree of neurogenic, some degree of nociplastic, that is central sensitization. The nervous system is adapting to this persistent signal that's coming forward. Another language is what I started the conversation with, these interference in functioning, these comorbid conditions that impact the severity of pain tend to become more prevalent as the disease progresses. So if you're unable to manage a chronic arthritic condition over time, certainly you're going to develop the mental health conditions that are comorbid with that. We understand this, but also that's reflective of change in the central nervous system. So when they find individuals who have a strictly osteoarthritic condition and they manage these patients, you do get some benefit with these medications that are used ostensibly for neurogenic pain or neuropathic pain. And this is a study in patients with comorbid fibromyalgia pre-existing that's then superimposed on osteoarthritis, found that pregabalin does have meaningful benefit in reducing pain, etc. So that's kind of an important point and a reason to always remind ourselves that to one degree or another, using these medications, because when we're using, the difficulty with those medications in that terrible slide before with all the garbage in it and all the challenges with respect to number needed to treat and dropping out because of side effects. What we do see with those medications is sustainability of effect, right? There's good data that says if you do get somebody into duloxetine, you do get somebody into pregabalin or even topiramate on those individuals that respond, they will respond to the same degree over the course of 1, 2, and 5 years that they do in the first 3 months. And that's very important when we're talking about these kinds of conditions that we know will be ongoing. Again, this is that study that talks about when you switch gabapentin for pregabalin, you get an improvement in pain relief, even in individuals who didn't respond to subtherapeutic or therapeutic doses of gabapentin or who dropped out because of a failure to tolerate the medication. It's still rational to give it a try. And I think that's kind of a significant finding for those of us because it certainly simplifies the management, especially when you really have a hard time understanding what amount of gabapentin an individual is really actually absorbing. All right, obviously. All right, I wanted to talk about this a little bit, and this is something that I think is probably important. It's my world and what have you, but if we notice all of these conditions that come forward are challenging to manage for patients with medications. And that's, I think, really critical. I'm going to go maybe one more ahead here. Yeah, I'm going to talk about this one first. What we understand with ongoing pain, we use diabetic peripheral neuropathy as an important one because it's so prevalent and it's so debilitating and therefore so costly. What we see with respect to the difficulty with patients, but also the cost of the healthcare system, is that individuals with diabetes, type 2 diabetes, with unmanaged neuropathic pain use twice as many healthcare resources and have poorer outcomes than individuals who don't have severe neuropathic pain. That's pretty easy to understand, but the rationale, therefore, for treating these individuals despite the obstacles is really out there. And the limitations of medications are a challenge to us, even under the best of circumstances, when we get an individual to tolerate medication management with respect to neuropathic or peripheral neuropathy pain, we're at best getting a 50% reduction in pain. That's meaningful. That improves quality of life. it improves function, it improves sleep, it improves mood, employability, and all those other things, but it's still 50%. And that's been our challenge in the past, and that remains a challenge. But it's not just peripheral neuropathy, right, and diabetes. It's all these other conditions. It's chronic back pain. It's all kinds of other, musculoskeletal conditions, osteoarthritic conditions in individuals who have medical comorbidities that aren't able to be treated. So my point on this one is that I think we need to be careful about just sticking with medications. I think we really, as a healthcare system, should do some work to rethink the cost benefit analysis of what it is that we're doing. And this is data that I think is really kind of remarkable. And what we've had in my space is a real renaissance with respect to the management of chronic pain conditions with interventional treatment. I'm using the analogy, we sit here and we're talking about individuals with substance use disorder, and a lot of our training here is that, when somebody has substance use disorder, of course we want them in behavioral therapy. Of course we need cognitive behavioral therapy and all the tools that we have. We manage it. We have all the different ways that we can manage this, but we know and we've learned that medication management for substance or for opioid use disorder, for example, is uniquely effective. It really reduces the risk of relapse and reduces the impact of this disease on function, and therefore, over time, greatly reduces both direct and indirect societal costs. So I'm bringing this forward as something that I'm not sure this is generally known, but for years we've used spinal cord stimulation as a way to manage certain pain states, whether it's phantom pain or post-laminectomy pain or back pain or what have you. But in the last several years, there have been some real advances in spinal cord stimulation for peripheral neuropathy. And the kind of improvement we're seeing is vastly superior to all combination of rational medication management. We are seeing individuals that are having 80 or 90% reduction in neuropathic pain, peripheral neuropathy pain with spinal cord stimulation, to the extent that we are able to discontinue their medication management going forward. And what's not understood about this is the resultant direct cost effectiveness of this, as well as the indirect cost effectiveness, because we're also developing some information that shows you do get marginal but gradual and sustainable improvement in nerve functioning in individuals that are responding to spinal cord stimulation therapy. That is, because you're providing this therapy, you're actually improving the neuropathy. And so it's something that's challenging for patients to understand, but once you see it, you really see it. And the data is showing, these are random RCTs that are really showing long-term benefit outside of medication space. So for years, we've been limited because we didn't have any therapeutic options for this kind of pain condition. And yet now that we've really focused on this, we're getting some change. And the same is really true for multiple other conditions. Individuals with osteoarthritic conditions of joints, for example, a lot of them have medical comorbidities. We can't replace a joint, or they've had a replacement and they have persistent pain. There are interventional things that we can do that provide far more than 50% reduction in their pain and improvement in functional status, which then results in global impact to their overall function. So it's a real plug, I think, I'm hoping to make, that says that data is here that shows we can be doing better. And sometimes what we believe is cost effective and or effective might not square with the developing data. Which, of course, brings us to opioid. Why we're here. Why we're here because with respect to chronic pain, all of the effective and sustainably effective medications that we were showing and that I was showing you in that really difficult set of slides on that study, hard to read and hard to interpret, but all of those show us that the number needed to treat, like I mentioned, was somewhere between just about 4 and 20. And the amount of patients, the number needed to harm is about that number. So people drop out at a rate that's about equal to the people who say, yeah, that helps me. Or I have to use lots of different medications before one patient says, thank you. That's our frustration. That's our challenge in today's environment. The difficulty, as we know, and where we're really sitting is if you're measuring number needed to treat, that is not a long-term measurement, is it? It's a short-term measurement only. It's in the first 4 to 12 weeks, how many patients say, I'm doing better on this medication. And unfortunately, the Purdue reps of the world used to know this, and the opioid class has a number needed to treat measure of less than 2. So if you start a couple people on opioids, at least one of them is going to come back saying, that's working, thanks. But the other part about that is the NNT number is a short-term measurement. And we have known for some time that opioids don't provide sustainable relief. I refer people to this kind of landmark study. It's Annals of Internal Medicine from 12 years ago now. It's a meta-analysis of all the best studies on opioid management for chronic low back pain. And what did we find? We found unequivocally in the first 16 weeks, there was solid evidence that opioids provided relief. After 16 weeks, depending on the quality of the study and the measurements used, the rate of the benefit quickly dropped down to baseline by no longer than 6 months. Some of them are earlier, but oftentimes at 6 months. And from 6 months through the end of life, if you have studies that we're looking at that, all of the studies essentially universally found that management with opioids was associated with poorer outcomes than no treatment at all. Think about that again. So what you're providing with patients with opioids is a treatment option that will provide relief for short term, and in 6 months, the relief goes under baseline. So you're now actively causing harm with the symptomatic relief for individuals before you even think of the risks to their overall functioning. Because as we know, depending on how you look at it, these individuals have a prevalence of substance use lifetime of 24%. I would make the argument that a lot of that is population bias, right? Because like in that first slide that I was talking about with respect to pain catastrophizing and emotional regulation difficulties and interference in quality of life and sleep interference and what have you, individuals who will persist with this, with the use of, will say, hey, I want that opioid. It's still effective for me, or it's doing something for me that I like, whether or not they're dependent on it psychologically. What's going on is they're trying to manage another part of their condition with this medication versus something that would be actively clinically effective. So that's why those individuals, it's probably another way to say that is the people that we tend to be pressured to prescribe for are exactly the people who are unlikely to respond. And that isn't a statement just about development of dependence. It's a statement about the other parts of their functioning, whether it's emotional regulation or what have you. So that's why we really have gone away from the use of opioids in chronic pain treatment, I think, as a rational therapy for the most part. However, that doesn't mean, and I would make the argument that that shouldn't mean that we force taper individuals, right? Because most of these individuals are getting some short-term effect or they're perceiving effect with these medications. They're just not getting a benefit that's a sustainable one. And so if you deprescribe, then you cause a harm to them in other ways. We understand increase in mood disturbance, substantial increase in suicidality, and really we're blaming the patient for not responding to therapy that was maybe irrational in the beginning. And what's really nice about that is that's where we're finding that we've got a unique opportunity with buprenorphine in the absence of substance use disorders to provide a different kind of a benefit. So buprenorphine is a different molecule with respect to how it interacts with these individuals. We don't fully understand it yet, but what we're learning is that in individuals who have either responded or ineffectively responded or have developed adverse effects limiting the ability, substance dependence and what have you, switching to buprenorphine, irrespective of those other conditions, improves pain relief and quality of life and sustainability. And this is really being demonstrated across a number of different studies that are looking at this in a number of different ways. This one I think is a really a fascinating study, and it's not that new, right? It's 10 years old. What it does is it takes individuals that are on very high doses of opioids, 200 to 1300, mean MME of 500, and what they found was these individuals come into clinic and they're on these high doses of opioids. Their VAS scores are somewhere above 7, and they come in and they are switched into buprenorphine therapy. And I should make the point that none of these individuals who qualified the studies had a diagnosis of opioid use disorder. They were just being chronically managed for a chronic pain condition with high dose opioids with a lack of success. And what happened was when they were switched into buprenorphine therapy, they had a 50% pain reduction, improvement in those other measures of quality of life, and more than 95% of patients subjectively thought that the pain relief alone was substantially better than what they were getting on their high dose opioids. To me, this is really important data, and it shows us it. And what I like about that is when you look at this, you see how buprenorphine right away fits into that other category of those other medications, right? A 50% reduction in pain is meaningful, and this is sustainable, and it improves those other measures that are important, and it's doable. And so, unfortunately, we all walk around with this concept that Suboxone treatment is something scary for that person who we don't want to treat. And I know this audience doesn't agree with that, but buprenorphine therapy is an effective tool in individuals for the management of conditions that are well beyond just use an opioid use disorder. And this shows us that it really doesn't matter what the MME was. I'm sorry if this is kind of hard to read, but effectively what it's saying is individuals on more than 200 MME or individuals on less than 90 MME, right? There's a lot of places where we wouldn't feel the pressure to change individuals away from less than 90 MME because it fits within the CDC guidelines, right? We're certainly not going to force taper these individuals. The last thing I'd say is we'd want to stigmatize these individuals. However, we can directly switch them into buprenorphine with an improvement in pain relief that's greater than we'll see with other medications. And I can give you a ton of these studies, but they're just flat out there and increasing. And it's also a lot easier to do than we think. We've had that discussion with prior echoes about how it can be done with microdose induction. And there's newer ways that we can do this. Patients don't have to go through some arduous withdrawal process. They can just either directly switch over or do so with the Bernese method, where you switch from one to the other in a graded fashion, so they never have to go through withdrawal. And what we see is really quickly, within 10 days to 14 days, individuals are on their new medication and they're doing better. And you're no longer worrying about their MME or the lack of long-term efficacy as you go forward. And so what we're really seeing in our space, and this is going to be something that we're going to continue to develop data on, and even within the state, I know some providers who are doing some studies that are looking at this. We are finding that when we switch patients over to buprenorphine, independently from any use disorder rationale, we're getting improvement in the symptoms that they're ostensibly being prescribed, to the extent that we're getting to the point where we're really going to probably in the next, if not now, in the next couple of years, we're going to talk about this as essentially the first line agent. And what we need to really re-educate ourselves about is the idea that partial agonist is not partial efficacy. Buprenorphine is more potent than hydrocodone, oxycodone, fentanyl, Dilaudid, morphine, and what have you. And there's even some data included here where a study that showed sublingual buprenorphine was equivalent to IV morphine even for kidney stones. So this is really important data. And what's going on with that is there's a different effect at the mu receptor, at the opioid receptor rather, and some of those kappa effects are different. and the mu activity is more, as we know, more tightly bound and what have you. So you get a different kind of an effect, and you get an improvement in opioids. So I'm including these studies in this, so it'll get into the it'll get in something you can look at. I can certainly get these to individuals who are looking for kind of the specifics or how to do it. Or we recorded some prior discussions. This is all brought forward from previous echoes. But when do you want to think about that? My point is almost always, if you're in a chronic situation, you want to switch away. Lack of efficacy, individuals are developing tolerance, they're not getting the relief, it's not sustainable. Certainly, if you're worried about use disorders, you're measuring for that. Improvement in drug-drug interactions, individuals who you think are going to be on long-term medication management, I would almost always say switching into buprenorphine is a positive step with respect to improvement in their care. All right. So that's kind of back to the beginning. Um, I would certainly love it if anybody had questions, or if we had a case or something like that, or if somebody wants to say, "Hey, I don't know about that data you present."
Thanks, John. Hey, would you be able to send those slides over to me this morning? I had a couple people ask for those. A lot of good
Abs-
information
abs-
in there.
Absolutely will.
So yeah, we've got a little bit, 7 minutes or so here. Feel free to unmute yourself if you have a question, or you can drop a question in the chat. Also, I'll mention check the chat. Alex put in a book recommendation called An Anatomy of Pain, and he sent a link to that. And Alex said he has a case if nobody else does. I'm not seeing anything, so yeah, let's go for it.
All right. Well, let's jump right into this. One of my PAs and I have a 40-year-old who has had a series of medical interventions, including spine surgery, cervical and lumbar, and the wheels have just kind of fallen off with his pain management. He bounced around a bit, but and he's been on various Schedule 2 full opioid agonists. I had a trial of buprenorphine in my discussions with my PA. I don't have this chart open, but I believe he experienced maybe some GI side effects, and so he's back on oxycodone. He has been getting into this pattern I've seen before, where he's in the ER a lot for dental pain, his chronic back pain. He's blowing up the phones, calling, trying to fill his medicine early. This is ringing a lot of bells, with what you've been talking about, and also just I'm concerned about him. Um, there's thought that he has opioid-induced hyperalgesia. His MME is not that high. It's about 50 maybe with his oxycodone. Also, we're thinking that he's developed, a fibromyalgia type picture. Very interesting the data you presented about activation of the central nervous system, generating fibromyalgia and central sensitization independent of the original cause. That certainly tracks with other challenging cases I've seen in my career. Also, the emotional lability, trouble regulating, which when you think about somebody who hurts all the time and their sleep sucks and they can't work and they're losing important social connections, like, yeah, I bet that would make me emotionally dysregulated too. I'm sure I'd be crabby. So again, this is just all very, rings very true when I think of some of the, most emotionally challenging cases for me, that I've tried to help over my career. So my question is that in doing some reading about opioid-induced hyperalgesia, I considered possibly trying to rotate to methadone because I found an article recommending that for efficacy. However, this guy is at fairly high risk of a therapeutic misadventure. And I'm thinking either going to one of the high-dose duloxetine or pregabalin, like you had mentioned, and staying away from methadone because he's never overdosed, but I think we're definitely in range for that. And I'm worried that I don't want that to be where we wind up because I was inadequately cautious. Do you think going back to buprenorphine, maybe with the induction with a patch, and then just getting to one of the higher levels of buprenorphine dosing, either any data on the patch versus sublingual? I mean, again, reassured by seeing the I've seen patients who've done well pain wise, but I had not seen the data and the perspective that partial agonist does not equal partial efficacy.
Right,
So that's really reassuring too. I mean, it
right.
jives with what I've seen, but again, it's nice to have data to tell patients that more certainly.
All right. Well, that's a great question, and that's a super common scenario, and I think a lot of us face that. I know we do here, and I'm gonna start my answer with a different question. And you said he had when you first switched over, he had GI side effects, and that made you back out. Can you go into that a little bit more specifically? Because I think the whole answer is right there.
Yeah,
Probably don't
I'm
remember,
wishing
right?
I would have got by my
Okay.
computer. So,
Fantastic.
yeah,
That's fine.
it's been tried, and he was like, "No, that didn't work," and so
Okay.
we wound up, I think, a little bit being pushed back into doing something else, basically.
Yeah, right. So you've got the fear, you've got the anxiety, the hey, look, I'm not doing well, but I know without that I do worse. That kind of discussion, very anxious, and what are you telling me? Are you telling me I'm just an addict instead of, really trying to help me, et cetera, et cetera. And that coupled with the one thing that happens with switching into buprenorphine is that you can develop some opioid-like side effects. At the same time, you can develop some withdrawal type symptoms that get commingled. It's the phone call is, I don't know, it's just going terribly. Get me my medicine back. And you have to train your staff and you have to train your ears to listen a little bit more carefully because really, um, I, what the whole trick to me is understanding that you have to switch from a legacy opioid into buprenorphine, and it's a variable conversion factor, essentially probably based on the patient's physiology and how much opioid kind of simmering dependence is going on. And the whole trick on that is a slow microdose induction. And by that, I mean continue to prescribe their legacy opioids and very slowly fill in buprenorphine dosing in a fashion that takes a long time. Because remember, buprenorphine half-life is 35 hours, and we've had whole echo talks on how you do this, but you don't replace one with the other. You just say, I want you to add a little bit of buprenorphine, and I can send you any number of slides on how to do this, but you slowly bring in the buprenorphine and you just tell them, I want you to just stop your medication when you don't think you need it anymore. So you go 2 weeks while they're continuing to take, you say it's around 50, say it's, let's just say it's, 7.5 of oxycodone 4 times a day or 5 times a day. Take it 4 times a day, 5 times a day. I don't care. I want you to take zero point 0.5 of buprenorphine once a day, twice a day, 3 times a day. Then I want you to take 1 milligram of buprenorphine twice a day. You can keep taking your oxycodone, don't care. But sooner or later, they're just going to say, as you fill up their receptors with buprenorphine, they're going to say, I'm not taking any more oxycodone, but they get to pick the pace of that. And that's when you've made it. And what you're going to see is, yep, there could be some short-term nausea that develops, so you manage that with Zofran. There could be some cramping that goes on because they're not dosing themselves quickly enough with buprenorphine. But if you hear whether it's too much or too little, it's really an answer of they're going too slow or too fast. But if you do it that way and you give the patient control of that process, and that's the same as saying, I'm not condemning you or stigmatizing you for where we were. It was just something that's not working. Don't worry, we're going to make it better. Then everything, all those challenges go away. And then at about 2 weeks, literally 95% of patients, and I think it's higher than that, say, wow, I didn't think that was going to work, but I feel great. And my pain's better. I'm sleeping better. I feel more like myself, all those interference, etc. But it's just a matter of getting the timing right and being confident with the patient and not let them feel like you got to take this away. And I would say going to methadone or just using duloxetine or Lyrica is probably a bit of a fool's errand. You really have to answer that opioid ineffectiveness question first if you're going to get relief in pain. I hope that answers your question, Alex.
That's amazing. Yeah, thank you very much. And if this isn't a demonstration of all teach, all learn, I mean, I certainly don't know it all, and I am going to go find my PA and revise our game plan for this unfortunate soul, and hope we can help him here. So
I'll tell you
thanks.
what, and this is a time for to kind of put a plug in. That's part of this echo process, right? Will tell you before we get off this is we have, Todd and myself and all of us, you know, we have ability to connect. So if you ever have questions about that, call us directly. We're happy to help with that because once you've done it a couple times, it'll just be so um, rewarding, and you'll be fully confident in it. You'll see that it works. So that's for anyone if you're interested.
Yeah, yeah, absolutely. Just feel free to get in touch with me, and then I can connect you with Dr. Massey or any of the other experts on our team. We are at the end of our hour here. There's a link in the chat to grab that survey and get your certificate. I also sent out an email. Uh, John, we have a couple of questions. We can do those now, or we can do those. I can send those to you in an email. What's your preference if you need to get back?
I can stay. I know people are going to hop off, of course, but I am happy to answer questions right now if um, um, yeah.
Sure. We just have a couple of them. I can
All right.
we can
I
get to them probably quick. But if people need
want
to
to take
hop off,
Brandy's
go ahead and
first.
hop on. Yeah.
Elaborate
Yep.
on the
So yeah, Brandon,
okay.
elaborate on the idea of forced
All right.
tapering. Yeah. Go
All
ahead.
right. Quick. Quickly this. If somebody's on opioids that aren't effective or you're worried about them and things aren't going well, the CDC guidelines that were revised in 2023 say do not force taper individuals. It's not the right thing to do because it literally increases morbidity and mortality. They do poor. They go outside of the medical world to find their opioids, and that includes fentanyl in this day and age. So overdose and or suicidality is associated with forcing an individual to get off a medicine. So if you're the provider who has been writing for a medication, or if a patient comes to you and they're on medications that you think, yeah, that's not in their best interest, I'm not all about that. In a somewhat surprising fashion, the data really says you shouldn't just say, I'm not going to do that. You certainly don't fire an individual because it's not working. What you really want to do is use those motivational interviewing skills, work with the patient and say, I got a better plan. And the better plan is what we're talking about with respect to switching into buprenorphine and managing it that way and then going these other medications because that is patient centered. It prevents the risk of short-term morbidity and mortality by putting somebody cold turkey. And it really is a more of a medical thing to do, isn't it? It's it's not right to stigmatize a patient, and it certainly isn't helpful to say, well, that's the dumbest thing I've ever seen. We got to stop that. It's really more effective to say, how about we do something that's more effective? Can we work with you? I'm going to show you a different way. And it's really, I think the key to this is to do it slowly and continue to prescribe those legacy opioids for a defined period of time, whether it's 2 weeks or 10 weeks, but we're going to switch you into something better. And as we do that, we're going to have to kind of work through the individualization of this care. But at the end of the day, you're going to be on a safer medication. It's going to work better. It's going to be sustainable. And then we've got other things that are going to work. So forced tapering, and it's specifically recommended against that. And it was really thrown at us because of the insurance companies when the CDC recommendations came out and they said we won't cover anything above 60 or 90 MME. That's absolutely inappropriate to do from a standpoint of regulation or the standpoint of insurance companies or hospitals or what have you. It's better to do this the other way. So that's what I mean with that.
Great. Okay, and then we have, let's see, two pretty quick questions here from Lisa. She asks,
Yeah,
in my limited use of buprenorphine, my patients have complained of fatigue with the medication. Any suggestions?
um, it's it's uh, it's probably evidence that with the buprenorphine, the the side effects of other opioids aren't showing up, so they're getting a little bit. It's probably a dosing effect, Lisa. And there's the trick with that is you got to remember the 35-hour half-life with buprenorphine means it's easy to stack doses, right? So you're taking it once or twice a day if you're using sublingual and what have you, and that's sort of building. So a lot of times when you're having difficulties with fatigue, I I lower the dose until they don't have fatigue, and then you wait about a week because that's when they're going to stabilize and they're going to get the relief without the side effects. And that also fits in with your next question about naltrexone for chronic pain. Um, Super low dose naltrexone with respect to fibromyalgia and what it's doing, there is some data that shows that's helpful, but what I've been seeing a lot of purportedly low dose naltrexone is really kind of sneaking up into higher dose naltrexone, so it might be doing something different than they think. And there is probably some similarity between really low dose naltrexone and really low dose buprenorphine. They're probably doing something similar, but the challenge is if you're using more than those ultra low doses of, below certainly below 2 milligrams of naltrexone, then you might be causing some antagonism effect that you wouldn't be able to reverse effectively if something happened short term. So it's a little faddish right now, and I think that you'll see a lot of places that are out of state compounding pharmacies that make a lot of hay on we're gonna specialize this low dose naltrexone, and it does help some people, but I think it's probably um, uh, yeah, it might be overstated sometimes.
All right, I think that's it. Thanks, Dr. Massey, for the
Thanks,
great
Scott.
presentation and sticking around and sharing your expertise. And thanks everyone for staying a little longer. That'll do it for today. We'll hope to see you all in a couple weeks. Todd's got a talk on nicotine 2 weeks from now. Thank you.
Thanks, everyone.